Hello, everyone. Thank you for joining our LinkedIn Live today. My name is Stephanie Dorwart, and I'm the owner and CEO of Altius Healthcare Consulting Group. For those of you who are unfamiliar with Altius, Altius focuses on transforming the financial and operational performance of hospitals and healthcare organizations through workforce optimization and productivity. Today, I'm really excited because we're going to talk about lessons learned from high-performing units and mastering productivity. And I'm so grateful to be joined by my colleague, Randy Lynn Lucas.
Hi, thank you. I'm excited to talk through some of these productivity initiatives and solutions around productivity for some of the more challenging areas that we're hearing about from our clients.
So one of the reasons Randy Lynn and I wanted to join all of you today is we're getting very, very close to the end of fiscal year or calendar year 2023. Regardless of when your fiscal year starts, whether it's January 1st or July 1st, we're coming into what's really considered the end of the year and the holiday season. And if you haven't worked in finance or retail, maybe you don't know the term Q5. But in a lot of industries, there's a concept of Q5. And Q5 is really the period of time from December 22nd until January 15th. And in retail and a lot of organizations and a lot of industries, that period of time is what separates their performance from everyone else. If you have a great Q5, you can really deliver on everything. We don't talk so much about Q5 in healthcare, but the holidays are really when we can separate, because for those organizations that double down on productivity now and double down on doing the right things now, you can really gain a lot of momentum. So we're going to focus on that and talk a lot about what high-performing units do, what makes them different, and the importance of you being creative today and making change today so that you can head into 2024 strong, regardless of when your fiscal year starts.
Absolutely. I think you never want to lose that focus. You never want to take your foot off the pedal, because we want to make sure that we're always gaining momentum and we're getting kind of that snowball effect around productivity and workforce initiatives and improvement. And when we think about, all of the barriers or the reasons to not that come up, I think we've heard so many different reasons why we can't make a difference, or we can't make decisions in that Q5 time period. We're not saying to go hard and reinvent the wheel in that time period, but really start to focus in on what we can start to do immediately in January to make an impact.
So earlier this week, I had one of our clients talk about the fact that they're not going to really be making any decisions or making any major changes probably until the middle of January or later. And I want all of you to just think about that for a minute. We're sitting at the end of November. The middle of January is, 6 to 8 weeks away. And if you don't make any progress or change your plan in that period of time, basically 1/6 of your year is spent waiting. Mm-hmm. And every minute that you wait are opportunities that you could have really realized.
Yep, absolutely. And I think the other thing that we hear too is we have too much going on, right? Well, there's always going to be a lot going on. It's healthcare. There's never a dull moment, right? Isn't that what we all experience? And so thinking about adding another thing to somebody's plate, yeah, that can be overwhelming. But if we talk about the why and we talk about, the importance of making some of these changes, I think we can really bring people on board and get that buy-in.
I could not agree more. And one of the other things that we hear is we're going to make some changes, but we're not doing it until once our technology is in place. Mm-hmm. Our new EHR is coming. We're going to automate. We're putting in place AI or artificial intelligence. Randy, what's your perspective on how technology plays into anything, and what should organizations do when they have technology programs coming, but they're not in place yet?
Obviously technology is where we're going, right? Where we need it. It's going to solve some of the staffing crisis that we're seeing. AI is a huge focus point for 2024. But if we have poor practices in place, poor processes in place, then are we setting ourselves up for failure with that technology? So if we don't have efficient processes in place, if we don't have the right person doing the right thing right now, what's that technology going to do? Are we going to just be wasting those investments, those dollars, because we haven't fixed some of the root of the problem before that investment?
Absolutely. And that brings me to the next tie-in is one of the ways to make sure that you have that investment and capitalizing on it is leadership development. And high performing departments, high performing organizations and high performing hospitals or healthcare organizations really have a focus on their department leaders and making sure that they have the tools and the skills and the knowledge that they need to actually maximize. So today's focused all about how you can create a high performing unit. What does it mean to have a high performing unit, and what are some of the strategies involved? So I love all of you that are joining. If you have a particular department that you're in charge of, feel free to drop it in the comments or the chat. We'll make sure that we touch upon strategies for your area. If you're catching this on the replay, we always go back and watch our comments. So feel free to drop your departments or your areas after the fact, and we'll still come back with you with recommendations and areas and things that you can do in your area to create the high performing departments. So, right now, productivity and our clients, we're hearing that they're not necessarily getting credit for everything, or no one's paying attention to all the work that I'm doing. I'm only measured on patient days, or I'm only measured on, the registrations, and my team does all this other stuff. Let's talk a little bit about, what it means and why we have to measure everything, and then dive into some individual departments.
Well, I think when it comes to productivity, I think first off, we're passionate about it, right? As a department leader, we want that credit. We want everybody to know how hard we're working. We want the acknowledgement around our staff. And sometimes what makes it a little bit complicated to capture everything is because we'll condense things into one department. We'll have a cost center that includes multiple functionalities, or various positions where that volume indicator that we might be able to capture just doesn't get everything, right? It doesn't cover 100% of the efforts. But if we can get to that 80% or 85% of the efforts that are happening in that department, that are driving the revenue, that are building the revenue, then we're in a great place. Then we start to build in some of the other functionality that might be happening in that department, because cutting everything out into these micro little cost centers isn't going to benefit anything. It's just going to create, just more work and effort for finance, right? To have those various small cost centers. So we put everything together and it makes sense. And that also lets us cross-train, which is a big thing in productivity. But
I think one great example that we can use is the operating room hours. It's an area that we get asked about a lot, because when you're managing operating room hours, you're managing your operating room volume. Typically, you're only tracking wheels in to wheels out.
Right.
And that's only one small piece of that procedure. That might be 45 minutes. It could be an hour and a half. But there's all of the turnover time. There's the scheduling time. There's the time that it takes to actually prep the patient, the pre, the post, and all that has to go into the indicator in some way, shape, or form. So we always get asked about, well, that's only wheels in to wheels out. How do we take everything else into consideration?
Yeah, absolutely. And that all goes into your target, right? So when you think about all of those little pieces of work, or big pieces of work, that all gets combined into your target. So while your indicator is the hours, those case hours, your target is giving you the credit for it. And so understanding what everybody is doing, and that's the art around productivity, right? It's an art and a science blended together, because we're looking at data, but we're also looking at functionality and making sure that we're inclusive of all of it, so that that target is real, it's meaningful, and it's achievable for the department.
So going along the lines of what do high performing departments do? In this example, high performing departments will understand what that target means to them. They'll break it down, as Randy Lynn mentioned, into the little pieces, and then understand how they vary from best practices on each of those components. We're talking about the operating room. They'll look at the turnover time, understand how their turnover time compares to best practices of other similar organizations on turnover time, look at where they are, and then how can we get 1% better? How can we get 1% better? And always look at turning the dial. They might track the information on the length of the cases versus other organizations. So it's understanding all of the different components and metrics, and then building out plans to improve upon all of those. So we're going to dive into some other examples. And one of the first places that we want to talk about is OB care hours. OB is such a complicated area, and there's so much activity going on. And whether you're, measuring your organization on deliveries or you're looking at patient days, it's very complex. And it's hard to measure what the OB activity is, because there are so many different facets of that.
Yeah, and I think that that's one of the areas where we get the most concern or questions around making sure everything is included, because you have triage, because you have labor and delivery, because you have postpartum, you have couplet care, you have all of those things that go into that episode of care for the patient. And it's not all counted when you look at a patient day. It's not all counted when you look at the number of births. And yes, it's built into the target, but as somebody that has to operationalize that target, and you're looking at something that's telling you have 28 hours per delivery. Okay, well, how do I even begin to break that down? And where do I look and where do I start? But then we didn't count anybody in triage. So all of these labor rule outs that are coming in, your NSTs that are coming in, we're not counting them. And so as a manager, you start to feel the pressure of how do you get credit for all of the work that you're doing? And so something that we're seeing and we're working on with our clients is using a care hour. So from the time you get there, if you come in and you're in triage, we're going to start counting your care hours. And then we're going to count your care hours through labor. And then we're going to count your care hours through that postpartum and couplet care. So it's the complete episode of care, regardless of where you start in it, right? Like, so if you're starting in triage, you're starting your labor rule out, or you're going home, those hours are going to count, right? Then if you come in and an hour in labor, we're going to count those hours and your postpartum. So everything is included. And now we're really seeing the full depth of the work that's being done within that department.
I think that's a great example, because it's important for us to count all of those hours, because it does play into effect. And when you're asked to, put together a plan of improvement, or, put together a plan to meet your targets, you have to understand all of the hours and staff that are involved and where that plays into it. And if you don't track everything and you don't have a game plan on how you measure all of that, it's very difficult. And you can't actually divide and conquer your plan and understand how those things play into each other.
And I think with OB too, the trend that we're seeing with that the LDRP model is that, everything is all in one. So where in some instances we had it categorized and we didn't have the cross training across the various areas, now it makes it even harder, because we're combining everything into one. That team is being cross trained as they should. And how do we manage that productivity if we're not going to transition over to those care hours?
And the cross training is really important, because it does provide us with more flexibility. And in today's environment, with some staffing shortages and challenges, it makes it a lot easier for us to respond to some of those needs when we have the LDRP model in OB. But if we're not tracking things appropriately and understanding those nuances, it's difficult to see those progressions and to see that improvement. So I think tracking and trending is definitely the way to go in, OB and LDRP. So next area that we're hearing a lot from our clients is in the emergency department. We're seeing a lot of changes happening currently within the border patients. We're seeing a lot of components where there's length of stay issues. It's taking longer and longer to get the patients from the emergency department up to the acute care floors. We're even seeing bigger issues with actually getting the emergency department patients back into the emergency department because of the borders. How can hospitals work to capture the hours, and how can that be included? Because traditionally, emergency departments for productivity are measured on visits and visits only. And the visit for an emergency department patient is much different than an emergency department boarder that's already been identified as being an ICU patient or acute care patient, and they have comorbidities and they need to be moved up to the patient floor, but now they're in the ED. So how can you balance all that, or what should hospitals look to do to balance that?
So I think that first off, it's acknowledging that we need to provide that care, right? Everybody knows that. We know we need to provide the care for those. But it kind of plays into that contradiction around, well, we're using visits. And so how do we make those adjustments? Do we continue to adjust our target so that we don't have a variance, because the variance is there because we're caring for the border patient? So, one way to do it, and one thing that we've been doing with our clients, is creating a supplemental report for them that brings in those border hours. It's actually equating that border hour to a patient day and giving them that hour per patient day kind of credit, and showing them how many FTEs they need or how many hours of coverage they need for those border patients, so that we're balancing it. And we're looking at it every 2 weeks, as opposed to looking at the average over 6 months or the average over a year, because it's different and it can vary on a day-to-day basis. And when you're looking at it daily or bi-weekly, it really allows you to understand what the hours of coverage are that you need for those border patients. And sure, fixing the root of the problem is the ultimate goal, right? We want to figure out, how are we going to get the patients placed out of the house? How are we going to get them discharged? How are we going to figure out transportation for them to get to where, whether it's home with a loved one, where they're going next. But so then we can get the patients out of the ED. But the problem is they're still in the ED right now. And when we don't sit down with the directors and the managers of the ED and talk through it and show them how to make those calculations for the right number of hours of coverage, then we're just kind of ignoring the problem. So giving them that tool, giving them that calculation is key to understanding the coverage that we need.
Right. And when you ignore the problem and you ignore the issue and you don't adjust for that component or that target, you basically are devaluing the work of the emergency department on staff on some level and the manager. And that breeds, burnout, it, breeds more frustration. It causes more issues. So just giving the respect to the department, making the minor adjustments. Sometimes it's only going to adjust it by a tenth or, it's not a large amount. But at least acknowledging it brings everyone on board and makes sure that you're moving in the right direction.
And doing it consistently is key. Again, we can't just build a target adjustment that's going to be flat. We need to look at it every single day and understand, once we've calculated what that hour per is going to be and we have it, then we use that on a daily basis against those border hours and on a biweekly basis to understand how many FTEs we need. Because sometimes we build that adjustment in and now we're not quite on point with it. So we want to make sure that we are, on focusing on it on a daily basis.
And that just made me think about consistency and, the importance of updating your targets and updating your benchmarks and updating that consistently. We often hear from organizations and departments that they're using metrics from a couple years ago, or they're using comparisons from hospitals that do not match them at all. They might be a large community hospital of 200 beds, and they're using comparisons of academic medical centers, emergency departments, or comparisons of rural areas. And there's a big difference when your acuity level, is really treating those quick cases that are in and out within the emergency department compared to an academic medical center that are treating, urgent cases and emergent cases and crashes and other components. There's a huge difference between those two.
Absolutely. Understanding that range that you should be in against your peers and the type of care that you're providing, your patient acuity, your patient population. And patient population is a big part of it too. What transportation opportunities are there for your patients? Like, how are they getting to and from your organization? How are they, where are they going after discharge? Things like that. So that all plays into it and impacts that length of stay and the overall hour per visit for your patients.
Definitely. So the next thing, going along the lines of the emergency department that we're starting to hear a lot more of, and that provides a great solution, is a discharge lounge. And having an area that your patients can move from their patient floor or their bed and move into the discharge lounge while they're waiting to be picked up by their families or they're waiting to be moved out of the organization. How can a discharge lounge really focus on improving length of stay and focus on improvement of the process and help with the emergency department border situation?
Right, it's the whole compounding issue, right? So I think that we've seen the discharge lounge. Discharge lounges implemented in organizations and they've had really great success. And I think that it's understanding that once that patient is discharged, they are at a different level of care now, right? They're ready. They're just maybe waiting on minor things in order for them to be able to actually exit the hospital itself. So we move them into the discharge lounge. They're monitored. They have, staff there that's with them, but they are decompressing the unit, right? So we're not waiting until 8 o'clock to get that patient moved out of the room. We can do so earlier and put them into a very safe and caring a place within the organization, but now we can start to move people through, and that throughput is really starting to pick up with using and utilizing that lounge.
And another area that we're starting to see a lot of high-performing emergency departments and high-performing organizations focus on for productivity is also having a behavioral health ED. Or a segment or a section where behavioral health patients can also be moved and seen separately. So they're moved out of the ED, moved out of the border as well, and they can, move into a different location. So that's also a trend that we're seeing in a lot of organizations, taking space that might be near the emergency department, converting it into a safe space that actually is comfortable, pleasing, and can provide, a space for the behavioral health patients to actually have their recovery within the emergency department instead of being in the hallway as well.
And similar to that, there's also the thought around that lower acuity kind of space, kind of lower acuity room for your ED patients. Absolutely. Where they're kind of sitting more in like a recliner or more of a chair type area, and they can kind of be cohorted so that they're waiting on x-ray, maybe they're waiting on labs, but they're decompressing the bays in the ED for some of the higher acuity level patients. So again, it's just kind of thinking about things a little bit differently. How and where can we care for our patients so that they're still receiving high quality care, they're still having a strong patient experience, but we are moving things a little bit more efficiently through the organization.
Absolutely. Now, the next department that we're going to talk about is the pharmacy. And the pharmacy oftentimes, I believe, probably doesn't get as much credit as it deserves in relationship to patient outcomes and patient quality, because pharmacists a lot of times are behind the scenes going through the electronic health record, looking for all the issues, identifying medication problems that might cause concerns, and flagging them before they actually reach the patient. So it's a lot of time to go through those records and spend time on that, but yet that activity and those functions aren't necessarily counted. Another trend are the pharmacists being involved in the discharge planning and actually meeting in the patient rooms to go over medications and, even sometimes making sure the patient has the medications before they leave. And none of that's taken into account. So we're often having conversations with our leaders on the pharmacy of, I'm doing all of these clinical interventions and all of this antibiotic stewardship and all of these things, but none of it's counted. What should pharmacies do to make sure that they're accurately accounting for some of that activity?
Well, pharmacy is a tough one. Like right off the bat, it's a hard department to capture all of the work and the effort that pharmacy is doing, because pharmacy is a huge influence or impact on cost savings across the organization, right? So what they're doing is it's not necessarily revenue generating as much as it is cost savings, right? So that's where we need to focus. And I think gone are the days where we can use doses to capture the efforts of pharmacy, because now we've got doses. We're looking at, we'll just say for the sake of the example, aspirin versus chemo, right? So really, are they even of the same category? And they're not. And I think that's what pharmacists feel, especially when you talk to the pharmacy leaders. How are we going to compare ourselves on doses when there is such a disparity around the work and the effort that comes into those doses? So then you look at all of the clinical efforts, and how are we going to count the clinical efforts within pharmacy? And then you're going to look at inpatient work and outpatient work, and you're kind of compounding everything that they're doing. And so is it adjusted patient days? That's the answer for productivity for them. And I don't know that there's necessarily one really great answer around pharmacy. I wish that I had it. But working with the various pharmacy directors that we do, it's finding the right way to measure productivity in each organization and where their focus is, and helping them determine what's the best volume indicator, what's the best target for them to achieve the overall goals of the organization, as well as meeting the needs of the patients.
Yeah, that's such a good point. And I'm glad you touched upon the adjusted patient days, because a lot of times we hear that, well, adjusted patient days is a global standard and we don't want to use any of those global standards. But the benefit of, a quote unquote global standard or a key performance, indicator such as adjusted discharges or adjusted patient days is it's comparative. It gives you a great reflection of how you do compare against other hospitals and other pharmacies, because it can tell you the number of pharmacists that those hospitals have per adjusted discharge and how many pharmacists they have per adjusted patient day. And by using the adjusted patient days, you get that nice perspective on similar organizations like you with a similar adjustment factor. And maybe some of you are asking, what's an adjustment factor? Well, an adjustment factor actually adjusts for your outpatient percentage of care compared to your inpatient. And if you take all of that into consideration, an adjusted patient day is a perfect comparison for a pharmacy, where you can identify the pharmacists needed, the pharmacy to tech representation and perspective, and then all those clinical intervention hours that go into it.
And I think too, again, it goes back to like the culture and the goals of the organization. So some organizations look at pharmacy more of a fixed area, right? We're not really going to flex pharmacy. But then you have other organizations where no, that pharmacy is going to flex because that's the culture and the goal and the need around at that organization. And so actually to spotlight one of our clients that got creative around pharmacy with flexing is that they looked at inpatient census and they had a threshold around it. And when that census dropped below a certain point, they flexed. But they also created a report around outpatient volumes and what was scheduled on for outpatient procedures that would require pharmacy support. And they used that to then help with planning.
That's a great idea.
It is. It's fantastic. And it takes away that pharmacy doesn't flex. Pharmacy can't flex. And it shows you that there is a creative way and a data-driven way to flex the pharmacy staff.
I think that's a really important mention because you can flex pharmacy staff just like you can flex every department. And I think that's applicable to a lot of different areas too, whether it's finance, environmental services, nutritional services. You can identify those bands where you probably need a little bit less or a little bit more staff that day based off of the activity of the entire hospital, house, and outpatient activity. I think building those flex rules around your team and understanding when you should staff out and when you should staff down are really important. And that's another critical aspect of high performing departments, high performing teams, and high performing hospitals and healthcare organizations is they hold everyone to the same standards. Everyone's expected to flex up and down. It's not just, oh, you're a functional area, you're a fixed department. It's no, we're all flexible. We're all variable, and we all have to staff up and down based off the actual volume of the organization.
And I think that culturally that creates, I guess, a level playing field, if you will, for all departments, because then we're not just, historically, sometimes we're just focused on nursing, right? Because they're driving that inpatient census. And so we focus in on nursing and we forget to look at other areas. And that's really imbalanced when it comes to a culture around accountability and productivity and leadership development, right? We want to make sure that everybody is held to that same standard. And whatever that standard might be, it might be everybody's flexing, or it might be, we have thresholds for flexing. It could be certain positions are more of a fixed level and others are flexing. So really understanding what that's going to look like culturally across your organization.
Yeah, and you mentioned, flexing and talked a lot about leadership in there and the culture that you have to have regarding all of those decisions. And leadership plays such a large role in productivity. And, I know we talk a lot about the fact that productivity sometimes gets a bad rap. And often when we walk into organizations, the first thing that everyone does is coil really and get very nervous and, back up from us. And sometimes they don't even really want to meet with us, but very quickly we, shift the conversation because productivity is about improvement. It's really about what can we do to improve our processes? What can we do to improve our patient care? What can we do to have the procedure take a little bit less time, to use less resources, to use, a little bit less money? And that's leadership development. And that's where leadership plays into this. And this is such an important time of year that can separate strong leaders from others because you can lean in to doing more. Right now, everyone's taking their foot off of the gas, backing up, taking a little bit extra time off, taking breaks, stop. As we mentioned earlier, they're not making decisions, but what can organizations do right now to separate, and what can they do to actually make a difference? And, what can we do now to focus more today than we typically do so that we can have a strong December and a strong start to January?
Well, I think first off, just giving your leaders that support, that recognition. And one thing that I like to do when we start a project and we're starting to get to know the leaders is give them the opportunity to tell us what's going well. And really give them the opportunity to brag a little bit about their departments, because acknowledge those efforts first. Let's start by acknowledging that how hard these leaders are working, and give them that recognition and give them the support and let them tell their story a little bit, right? But then also, set clear expectations and everybody be held accountable again to that same standard. If we're all doing it, we're all doing it. And there's nobody that gets excused from the table for not being held accountable or not being set, having those same similar goals. I think that leaders need tools, they need resources, and they need support.
And I couldn't agree more. And it also goes to employee engagement and, just employee, you mentioned recognition, but employee involvement. in the outcomes and employee engagement in the decision-making process. And, yesterday we were talking with, a client about, the runway of change and everything. And they were talking about how fearful they are to actually make a mistake and how paralyzed they are to actually move forward. So they don't move forward at all. Whereas if you have 70% of the plan and you have 70% of the solution, and you think something's going to improve your productivity or improve your process, improve your organization, just moving forward, even though it's only 70% of the way done, is going to get you so much further than if you don't move forward at all. And if you move 70% forward and you keep moving, you can really change things and pivot and get back on course if you're off course. But you have to empower your leaders to make decisions and empower them at times to make those mistakes and to correct the course.
Absolutely. It's okay to make a mistake. It's acknowledging it and knowing that it's going to be okay, and giving those leaders that power, that empowerment to make decisions without necessarily having to ask for permission or having their hand held is really, really crucial, because we need them to get out there and start to make these hard decisions and start to look at the big picture of their department and see where there's opportunity for change and see how they can improve their processes. And, the leaders probably know deep down what they need to do to make those changes. They just need to feel like they can. And sometimes being given that push, or being given the why behind why things are happening or what the decisions are, and that communication is what they need. So give them the why, give them the support, and let them know it's okay to fail, because we're going to be here to support you and we're going to help you course correct.
I think if we can just end by saying, if you're aware that you have opportunities, you're aware that there's something that you could do a little bit differently, is to work towards that, because not doing anything is not going to move you forward. So doing anything at all and moving in that right direction is going to move the bar forward. And that's the difference, I think, between high-performing organizations and poor-performing organizations, is high-performing leaders, high-performing organizations are always looking for that one thing that they can do. What's my one next best move to improve 1%? And once I do that, what can I do tomorrow to improve 1%? And what can I do the next day to improve 1%? So just turning that dial one more step further and making a difference every single day. And if you can do that, your department will be completely different in 30 days and 60 days and 90 days.
Absolutely. It's changing the mindset, removing the can't and thinking about the can.
So we do have a question that we're going to address here.
How can leaders change or improve to encourage more productivity?
So how can leaders change or improve to encourage more productivity? So I think, number one, it starts with mindset. And you have to really understand the power of a positive mindset and focusing on growth. And growth can come by, accessing best practices within your department, reading professional journals, participating in webinars, seeking out best practices from consultants, but accessing knowledge and information, because if you have the knowledge and the information of things that could work, you can then start to apply them at your particular organization.
I would think just be creative. I would, think outside the box, and re-envision what you're doing and allow yourself the opportunity to think in that mindset and to think in that space where you aren't just saying that's how we've always done it. And I think that can really help with encouraging productivity improvement, and workforce design and all of those things is just stepping outside of we've always done it that way.
Step outside of your comfort zone.
Yes.
And if you continue to do things the way you've always done things, you're going to continue to get the same results. So identifying, what you can do to move out of your comfort zone a little bit and change one thing in the process or one thing in the day and trial it. And then once things did it work? Did it not work? And correct the course if you need to. I think leadership development is very important in continuing the growth mindset, and just access to information. Anything else that we want to share with our listeners today before we wrap up? Oh, we just have one last question that came in. It's a great one too. What role does continuing education play in leadership development? This is a really good one. One of the areas I think that we need to do a much better job in healthcare is the leadership development that we provide to our managers, to our directors, to our supervisors. We're really strong at recognizing someone that has leadership potential or that's someone that could be a really strong leader and promoting them. What we're not as great at is providing them with the financial acumen and the skills and the knowledge that they need to excel. Even just simple things as how do you manage change? How do you make decisions on personnel? So continuing education plays a huge role in leadership development because it bridges the gap between where you are now in your professional development and where you need to go to become the best leader you possibly can be. And leadership development and those skill sets and the mindset can continue to evolve, and that of course influences productivity.
Yeah, absolutely. And I think that, when you identify that strong individual that's promoted into a leadership position, there's a reason for it. And they are eager to learn, they're eager to grow. And so giving them the resources to do so is key. And when you think about getting promoted into that position, and it's kind of a congratulations and good luck. Yesterday you were with your peers, and today now you're managing them. And there's a lot to learn in how to make that transition. Like you said, the financial acumen, there's also how do you have a conversation with the budget team?
Right.
How do you have a conversation confidently around your productivity, around your budget, around then even moving into HR type situations, discipline, recognition, all of those things when you were just with your peers. And now you're at a different level and you have to perform at that level.
Perhaps you're aware that you may need another position on, the second shift, and you know exactly what that position is. But having the conversation, the financial awareness, and presenting it to the budget team to get the result that you need is a completely different skill set. And I think that's where continuing education and leadership development really come into play as you're working through that. And continuing education comes in a lot of different forms. It can be courses that you sign up for as a leader to get credits. It can be a webinar. They can be half-day retreats that your organization provides. They can be bite-sized nuggets of information that are available to you exactly when you need them through online learning. And I think that's one of the great things about options like virtual training academies and even mentoring and coaching is because when you're in the heat of the moment and that decision as a manager and you're not quite sure what to do or where to go, you can search for that 3-minute segment that you need on retention or the 3-minute segment on that difficult conversation, or reach out to a coach or a mentor to ask them how they would navigate through it. And I think that's how continuing education really plays in a performance improvement. Well, I think we've covered a lot of different topics today. We're just going to end by sharing again, we're going into what's Q5 in the retail industry, the end of the year. And there's a lot of time between now and January 15th. And we want to end by just encouraging you to make positive moves and build momentum in any direction. And just look at your situation and make decisions and act on those decisions. And as you make those decisions and act, you're going to move forward, improve your performance as a department, and improve your productivity. So thank you so much for joining us today. We look forward to seeing you on our next LinkedIn Live.